Okay, part 2 of airway management. We're going to go through the next P's. And the fourth P of the rapid sequence P's is to basically paralyze and induce unconsciousness. And that's honestly where the rubber meets the road. That's where you really are taking away the patient's ability to breathe and you're taking over. So what we do those simultaneously because honestly, the last thing in the world you would ever want is to know that you've been paralyzed and somebody's breathing for you. You just want that, you don't want that. So you have to induce unconsciousness. So the first, what do you guys use for your induction agent? How many people use Etomidate as your go-to drug? I know we do. Anybody use anything else as your go-to drug? What do you use? Propofol. Okay, anybody else propofol go-to? Propofol is awesome. Anybody use anything else at all? Yeah? Thiopentone. Oh, you do? Oh, good for you, actually. That's pretty awesome because we don't have access to that a lot here. And then somebody mentioned ketamine. So what is the theme of all of these is that you're actually inducing unconsciousness with all of these. Ketamine does it dissociatively, but the rest of them truly knock you out. You can, just so you know, use midazolam as an induction drug as well, but the dose is distinctly different than what you're used to. So what you're used to is taking a little edge off to reduce a shoulder, giving a milligram or two. To induce unconsciousness, it's 0.3 per kilo. It's 20 milligrams of midazolam to get somebody induced unconsciousness. So if you have that in your armamentarium as something you're going to use as an induction agent, the dose to induce unconsciousness is extraordinarily high. And your nurses are going to think you lost your mind when you order that, but that's the induction dose. All of those agents are fine to use. Each one has its nuances, and each one has its issues. And as long as you understand what you're doing, that's cool. And most of them need to be given first before the paralytic agent. So you really have the person out before they're paralyzed. I'm going to talk a little bit about Etomidate because Etomidate kind of hit a little rough patch for a while. I think some ER doc died and went to heaven and said to God, can I please have an induction agent that keeps people's blood pressure and heart rate okay, but knocks them out really quickly so I can just put them down. And I need this agent. God said, fine, have Etomidate, which is great. And a lot of us go to that agent on purpose because it's pretty hemodynamically stable. Not 100%, but pretty good. The issue that came up with Etomidate is addressed in these articles, and this hit about 8 years ago. Etomidate suppresses your adrenal axis, and it does. And a single dose of Etomidate, like we use in the emergency department, can suppress your adrenal axis. The original data came out of people on Etomidate drips in the ICU who were either septic or trauma patients, and they found that it increased mortality. And it was felt that that must be due to the fact that your adrenal axis was suppressed, and that must be what happened. It increased your mortality. So the next thing they studied was looking at, does a single dose like we do suppress the adrenal axis? And the answer to that is yes. There are a couple of papers in here that say Etomidate's a bad thing because it does that. The articles that I think are the most interesting to read are the two articles that are back to back. They're sort of the Jane, you ignorant slut version. So those of you, have you ever heard of Jane, you ignorant slut? Saturday Night Live. If you have no gray, you may not have. I said that in a resident teaching situation not that long ago, and one of the residents was saying one thing, and the other was, and they're arguing back and forth, and I said, well, Jane, you ignorant slut. And they all went, oh! How could you say that to a resident? It's like, no, that's Americana. Go watch Saturday Night Live. Get a grip. This is history. So these two articles are basically a point counterpoint, like Shayna and Shayna Alexander and Jack Kilpatrick. This is a point counterpoint. The first one of these two, which is abstract number 3 by Walls, basically says, look. Ron wrote this and said, I am the pro-argument in using Etomidate because the reality is there is no randomized controlled trial that shows, even in septic patients, that using a single dose of Etomidate changes the outcome of the patient. Yes, it suppresses the adrenal axis. They all bounce back within 24 hours, and there's no change in outcomes in these folks. And that's true. It's absolutely true. In fact, to this date, there's none that's out there. The other thing, though, is then Al Sacchetti, in number 4, he was given the Karn argument, don't use Etomidate. And he makes a very good point. We started this little session together with a hand for propofol, we've got thiopentone, we've got some ketamine, we've got midazolam. We have other options other than Etomidate for inducing unconsciousness in people. His argument is, if we have these other options that are equally as good, why take a risk that you might have a bad outcome for someone by giving them a drug like Etomidate if it's a septic patient in particular, particularly children? That's the area that's the biggest concern right now. maybe we shouldn't be using it at all. We should be using something else. And I'll leave it up to you. We still use Etomidate. We had a huge talk about this where I work. And we all just came down to this, the data is just not strong enough to make us go to something else on purpose, unless you really choose to have another agent to use. So we have choices. There's a bit of a debate about it. And there is an editorial out there that basically is titled, it's in one of the critical care journals, titled something like, ketamine is tantamount to, or using Etomidate for induction is tantamount to malpractice. I'm sure when Google Etomidate malpractice, all the attorneys over there Google it, that's going to pop right up for them for their cases they take to court. So just know there's an issue. Now, one of the things that you'll hear about probably tomorrow, and you may have heard about it a little bit. Was the ketamine talk done yet? Okay. So the key to SED study, it's abstract number 5 in there, is really truly a landmark study. And it's used for a lot of different sort of discussions. But what they did in that particular study is they took those sick people. It's a wonderful randomized controlled trial. They took 655 critically ill adults that all required emergent RSI. They compared a single dose of Etomidate, the way we use it, 0.3 per kilo, to a single dose of ketamine in dissociative doses, knock-em-out doses. So basically, head-to-head, compared those two drugs. They said, yeah, and they measured, oh, yeah. Yeah, that one is a mistake. There's a typo in that one. So the typo, if you look under dosing, blah, 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 it's like 4 or 5 lines down. It says ketamine. It says 0.2 milligrams per kilogram. That is wrong. It was 2 milligrams per kilogram in that study. I'm not sure how that actually filtered through the system. So it is actually a true dissociative dose they used in this particular study. They looked at the adrenal axis. It was absolutely suppressed in the Etomidate group, not in the ketamine group. But then they looked at outcomes, including things like all-cause mortality at 28 days, which is something I think we would all agree is a very patient-oriented outcome. You're dead or you're not at 28 days. They found there was no difference, whichever agent you use. Their conclusion on this was that ketamine is a safe alternative to Etomidate, but you could just as easily flip it around and say that Etomidate is just fine and is the same as ketamine. So that's probably the strongest argument we have for saying this is a safe thing for us to be doing. So that's sort of the issue that comes up with the induction agent. The sort of pairing to that induction is to paralyze someone. Now, how many of you have gone away from Sux completely and are like a rocuronium only shop? Does anybody do that? So some people have done that. Because the issue with succinylcholine, we all know, is we worry about some of the side effects of succinylcholine, the most lethal of which is hyperkalemia, inducing hyperkalemia in somebody who, for instance, I've done it, I didn't kill anybody, but I've had 2 really terrible hyperkalemic outcomes from giving Sux in people I didn't know had had a stroke. They were brought in altered. I didn't know they'd had a stroke in the last couple of months, and those are the people that are primed to get a really big potassium surge when you give them this fasciculating agent, this thing that actually causes them to depolarize. So we worry about that. So some people have said, forget it. I want to go to rocuronium only because it's a non-depolarizer. I don't have to worry about that. Totally fine to do. There's a bunch of debate in here as far as if one is better than the other. And I will tell you flat out, you get what you need from each one, but you pay a price. So succinylcholine in the doses we use, and please do not use less than 1.5 per kilo of Sux. Going lower doesn't do you any good. You can go as high, you can go to 2 per kilo, it doesn't hurt anybody. It's basically once you need to get to that plateau and then you've got them paralyzed. You get basically paralyzed within 45 seconds, and then they're out in 5 to 10 minutes. Fabulous. Intubating conditions are beautiful with succinylcholine. They're fabulous. Rocuronium, though, to get really good intubating conditions in a timely fashion, you have to bump the dose above what's recommended and above what they use in the operating room. So in the OR, they use 0.6 per kilo. In the ER, we need 1 per kilo. Because what you want is to get them paralyzed up front quickly. We want them down within a minute. And you get it within a minute if you have the dose of 1 per kilo. You pay a price at the other end. You end up with them paralyzed for anywhere between 20 and 45 minutes. So that's where make sure you think you're going to intubate that person, or make sure you have good backup, because if you run into trouble, you're going to be bagging them for 20 minutes, or you're going to have to go to some sort of backup. Both of them are fine, and honestly, it's a hair split. We still use Sux all the time where I work. Trauma center, we see 2,500 trauma patients a year. We use Sux routinely, but ROC is totally fine. The price you pay, though, because you have to use the higher dose to get the intubating conditions the way we want them up front fast, is you're going to pay the price at the other end. So either one is fine. And there's some literature in here that talks about it. The reality is either one is fine. Now, if we ever get the drug Sugammadex approved in the United States, which is a reversal agent of the non-depolarizers, then rock's going to have it all, hands down. Rock will be the way to go. But we don't have that yet. It hasn't been approved in the US, so that's not out there. All right, so we induce unconsciousness. There's the Etomidate issue. No, there's 5 drugs you can choose from that are completely fine. Rock and Sucks, equally fine. Just a matter of knowing what you get for what you use. Use the right doses. That's the Paralyze and Induce. The next step is to protect the airway. All right, protecting the airway, we taught people, for years I tortured people in the airway course. If they didn't do cricoid pressure on somebody when they were going to intubate, I'd make the mannequin vomit, make a big old mess, and cricoid pressure was just required. Somebody finally studied that. We do all this stuff without, it's just lore, we've talked about it forever, or the reason cricoid pressure was ever started back when is when they had to do crash cesarean sections on term pregnant women and found that they had an increased risk of aspiration. Well, your stomach is this big, right under your left clavicle when you're term and you're supine and you have tons of acid in your stomach and no esophageal sphincter tone, because that's what happens with progesterone and all the hormone stuff. So of course they're at a higher risk of aspiration. That somehow got bled into everything we do in airway management. The data out there that's the best, abstract number 12 is basically a review of does it really do what we think it does? Couple things. It does not prevent aspiration. Your theory is you're taking that solid cricoid ring, you're pushing it down against the esophagus, you're preventing this passive backflow of stuff in aspiration. It doesn't do that. Okay, they've done radioactive studies looking at C. Does anything come above it? Absolutely does. So it doesn't prevent aspiration. We all know that it can block your view. Right? So you'll be looking, it's like, God, oh, I just can't quite see. And you've got some behemoth up here doing cricoid for you. You say, let go. Oh, there it is. Got it. Beautiful. So it can definitely block your view. And if you're ever having trouble looking and somebody has cricoid, have them take it off. Okay, it will improve your view. It can completely block your ability to do BVM, especially in children. So, and we think about it. We do cricoid pressure during BVM sometimes because I'm going to prevent insufflation of air into the stomach, and that's what I'd like to be doing. If you have somebody doing cricoid and you're trying to bag and you can't get them to get chest rise, let go of that cricoid. Especially kids, you can squish their airway completely. Doesn't take care of that. So, and just to kind of be the nail in the coffin, there's no consensus on how you should be doing cricoid pressure. How much pressure? How hard should we push? Who knows? We don't really know. So cricoid pressure, just like the pre-treatment drugs are really kind of falling off the map, cricoid pressure is no longer considered a mandatory step to best practice intubation, and in fact probably should be eliminated unless you have a very specific reason to be doing it. So cricoid pressure is kind of lost. Now, one thing that you should be doing, adding to your practice though, is what's called bimanual laryngoscopy. If you're doing direct laryngoscopy, got your regular old standard blade in your hand, when you're looking, I usually have my assistant who can't get their hands off the neck. So I say, come here. Okay, go ahead and put your fingers in. Don't you touch, don't push. Put them over the thyroid cartilage. Then you look and you reach around, you put your fingers on top of theirs, and you manipulate the airway so that you get a great view. What you tend to be doing when you do that, just so you know, is push it down a little and push it to the right a little, which makes sense. If you think about what you're looking at, it makes total sense. That person's fingers are under mine already. I say, okay, just stay right there. Then grab your tube, pass your tube. It's called bimanual laryngoscopy, way better than cricoid pressure, and gets you the airway that you want, gets you the view that you want. So that's called the bimanual technique. So cricoid pressure, kind of gone. The next step is to actually place the tube. So now we've gone through the first 5 Ps. Now the 6th P is to place the tube. I talked a little bit about the preparation. You have several ways of doing this. Have any of you gotten rid, we were talking about this actually earlier this morning. Have any of you gotten rid of DL? You don't go to DL first, you go to something else first. What do you do first? Glide scope. What do you do first? Glide scope. Okay. How many of you have a CMAC? Okay. We have CMACs. We've gone to totally CMACs. I'll tell you the difference in a minute. So you're going to videoscopy as your first wine to do that. Awesome. And actually, I swear that will be the way we go once people have the money to have the equipment and the training to be comfortable with it. The key to placing the tube, I think, is to be good at your standard stuff. DL is fine. Get good at least one videoscopic device, or at least ask for one in your place, because honestly, videoscopic stuff is awesome. Get one extraglottic device around, so you have some way to at least get somebody oxygenated and ventilated if you're having trouble. And there's lots of those. There's the King LT, but what they do is they sit above the airway. They don't go down into the airway. And you're pushing air down through the glottic opening, but preventing it from going down the esophagus. And there's various versions. There's an iGel, the LMA, King LT, there's various versions of this. But that's a nice backup for you. And then have a bougie. How many of you have never used a bougie? Anybody never used a bougie? Because I will tell you, bougie was the secret that anesthesia hid from us forever. They had them like curled up in the pockets of their white coats here. You'd see this like weird, what is that, like hose thing in their pocket? Basically, it was this stiff thing that looks like a Coude catheter that's stiff. I'll tell you, bougies will help you. They're $6. You throw them away. They will save your hiney in so many different situations. That anterior airway with DL, I can't quite get it. Bingo, that's where it was designed for. However, you need to do a crike. Haven't done a crike in a while. Oh my God, I'm scared to death. Get a hole in there, stick the bougie down. Feed your tube down over that bougie. You can actually hold your hole open that way. If you're doing something like a videoscopic thing and you're having trouble with your videoscope getting the tube where it needs to go, put a bougie down first. Feed it down over the bougie. Bougie basically goes down into the trachea. It's stiff, so when you kind of pull it back and forth, you'll feel it bumping along the tracheal rings. It's in. It's basically a Seldinger technique. You feed the tube down over it. The key to using it, just as a little trick, if you're using a bougie and you're using DL, so you're actually your old-fashioned DL, your muscle memory says, look, pass, take out. You're going to have to take an extra step. It's look, pass, but all that's in there right now is the bougie, not the tube. Stay looking, let somebody feed the tube to you, and now the tube goes in. Because it will happen, I guarantee it. And I see the residents do this every year. They look, they get it passed in, and their muscle memory says this comes out. The problem is now everything drops. You try to feed the tube down, it often gets stuck in the tongue, it gets stuck on the epiglottis. So keep looking and have somebody pass the tube over to you. They hold the bougie here and you pass it down. Bougies are awesome, absolutely awesome. So as far as passing the tube in general, DL is fine. There's a bunch of studies in here I stuck in there so that you know. The reality is all of the devices work. Each one has a different learning curve, and each one has its own nuances. So each one has a little bit of a trick to get it inserted if it's an extraglottic device, so what position it should be in, just little nuances, but they all work. Your job is to give yourself the options, if you run into trouble, of being able to pick one of those out there. And I honestly think videoscopic devices are the way we're going to go from the get-go as soon as we all get comfortable with them when we have them. We just opened a new ER like 40 days ago, okay, brand new ER. And in our trauma bay, every single trauma bed has a CMAC, and we have 3 rolling around CMACs that we can use anywhere else in the ER where we need it. That's a videoscopic device like a glide scope with one major difference to the glide scope. So what videoscopic devices do, and the reason that they have a little different way to be used than a DL, is that what you're doing is you're taking, instead of your eyeballs looking down a hole at the cords here, you're taking a camera and you're putting it on the end of my blade. And now I have a picture over here that I'm looking at, which is a great idea. And what tends to happen is you get this gorgeous picture of a glottic opening on your screen, and getting the tube to it makes you insane. It's like, it's there, I see it, I can't get the tube. I'll tell you the trick to every single videoscopic device out there, every single one. It's 4 steps. It's patient, screen, patient, screen. Be rigid. So take your blade, whatever it is, I don't care if it's a CMAC or a glide scope. Don't look at the screen. Get it out of your way. Get your blade correctly positioned in the patient's mouth and behind the patient's tongue, okay, before you ever look over here. Once you're there, you have this in the right position, now you get to look at the screen. And what you're going to see is you'll see part of your glottic opening, and you're going to now manipulate here so that the glottic opening is in the upper half of the screen in the middle. Now look away from the screen. Don't look there. Go back to the patient and take your tube, insert it in the patient's mouth. Each one's a little different. Some from the side, the CMAC's actually better right down the middle, but insert it in the patient's mouth until it's behind the patient's tongue. Now look at the screen. 99 times out of 100, you are in the perfect position to just ease it through. You're not ditzing against the arytenoid, you're not sticking over on the side, because you set it up the way the machine was devised. That videoscope is meant to be sitting, looking at the glottic opening in a position where you can have space to get the tube behind it and into the airway. It is, honest to goodness, if you're having any struggles with a videoscope, get yourself those 4 steps. I guarantee you're suddenly going to have it be magically better. One more trick with a glide scope, though. The paper's not in there, but there are several that have been published that say that rigid stylet that comes with the glide scope, buy it, keep it, get it cleaned in between. Trying to MacGyver one of our regular stylets, turns out that your success rate drops by about 10 to 15% if you try to MacGyver it with one of the sort of ones we have versus that really stiff one. It's called a rigid, whatever, it's a stiff stylet, I think is what it's called, the name for it. But you need that really to be successful. So the videoscope devices are fantastic. They're cheap versions, so that you know. So if you can't afford this $6,000 or $10,000 true videoscopic thing, there is a disposable version of one that I have no stock in any of these, but I bought one of these called the King Vision. What the King Vision is a little tiny screen on top that you keep. It goes in a little box that looks like a breathalyzer box, okay, that you can stick in your pocket, and disposable blades that click on it, that have a channel along the side that you slide the tube into. When you have the thing set up, you basically turn it on, defogs the end because it gets warm, slides right behind the patient's tongue. You do the same positioning on the little screen you're looking at here, and you pass it down. Piece of cake. Awesome. You keep the little thing because that's yours now. It costs about $900. The rest of those things are disposable. All those blades are disposable. There are fancy versions of that similar concept of it being self-contained that are things like the McGrath. There's pictures at the end there for you to see. But there's lots of versions of this. And I think the key to all of this is to have one extraglottic device you really love and you're good at, to have the bougie. If you have a videoscopic device, please get one if you don't have one, or you get one of these cheaper ones you can buy yourself. So you have extraglottic, videoscopic, DL, and bougie. And of course, where the rubber always meets the road is if you can't get somebody tubed and they're desaturating and they're not ventilating, is the reality is you can always go here. Okay, don't forget that you can, I don't care how much fat is there, in there somewhere is a trachea. So you can go find it. And that's one of the things that I think having a bougie around is handy. If you haven't done a crike in a long time, it's so scary. It's so scary. There are kits that give you a chance to do it percutaneously with the needle and the wire and the whole thing. But if you really need to do it, give it a whack this way, stick your finger in there, find the cricoid membrane, give it a little cut, and take your bougie. Slip your bougie in there. Okay, you'll feel it bump. You'll know you're in there. It's like, okay, I'm in there. I can then make the hole a little bigger and put the tube over it. So go ahead. Bougies are awesome in that regard. All right, so that's placing the tube. The last step is post-intubation management. Most of the time we get like, woohoo, high five, yay, we're done. How fabulous is that? There are 2 papers in here. I think it's 2, maybe even 3. I know of several out there, but these 2 are particularly disturbing that talk about how incredibly terrible we are at appropriate post-intubation management. One of these papers is on children. The other paper is for adults. And it basically just looks at how many people got the appropriate anxiolytic and analgesic medicine after they were intubated. It is appalling, appalling. In children, 90% of the kids in this particular paper, number 24, got ROC, which means they're paralyzed for 25 minutes at least. And only 13% of kids got no sedative whatsoever. So 13% of those kids could be totally awake in there and totally aware in there of the fact they're paralyzed and being ventilated. How scary is that? And the adults were actually worse. The data for the adults was terrible. There were only 4% of the adults that got the right meds. What we've done in our place, which you may have done as well, we finally just got to the point where for the practice, we were good at it, but we weren't uniform at it. And what we did is we now have a basically intubation protocol, little checklist. We call it our best practices, and it starts all the P's. It starts with the whole shebang, from positioning the patient and preparing everything, all the way down to check boxes for that post-intubation drug order, so that it doesn't get missed in all the chaos. It's always addressed. And if you choose not to do it, you have to explain why. So that it's explained why you have hypotensive, whatever you're worried about. But I think we're all really good at this. And what I love about this sort of evolution of airway management for us is that we're getting better and better. And we truly are learning what works, what doesn't, what we need to do, what we don't, and how to be really, really good at this, even better than we have been. Questions, comments? Did I get you out on time? right on time. Excellent. All right, thank you very much.